to a brand new state-of-the-art brain and mind care facility here in Chennai. Brain stimulation to psychological therapy, Ayurveda to yoga, cognitive stimulation to naturopathy, physical, occupational and speech therapy, we are the pioneers and innovators of integrative care for the brain and mind.
Welcome to Buddhi Clinic. Neuropsychiatry as a specialty is one that affects the brain and mind interface. And when we say brain, we know we have an organ there. But when we say mind, we touch our hearts, we touch our heads. The mind is really just the software in our brain, the millions of nerves talking to each other through chemicals. What do we have in our armamentarium to treat these patients? We have surgery for some, medication for many, if not most. But beyond all that, what do we have? And what we do have is rehabilitation, therapy, and care. Now, usually a person with a neuropsychiatric condition will have to go to various places in order to receive these treatments. Imagine if you could get all of them under one roof. Imagine if you could, just by traversing floors, meet experts in every one of these disciplines who are programmed, prepared, and equipped and qualified to help you. And that really is what we offer you here at Buddhi Clinic. The opportunity of blending modern science and ancient wisdom, the opportunity of being able to receive a very wide array of care treatments that can help you. So do come, visit, see what we have on offer, and I'm sure you will not be disappointed. In fact, I'm sure you'll feel exhilarated by what you see here. Thank you.
The basement houses the state-of-art neuromodulation facility. We have repetitive transcranial magnetic stimulation, transcranial electrical stimulation, which comprises of TDCS, TSES, pulsed and random noise stimulation. We have transauricular vagus nerve stimulation. Along with the neuromodulation, we have yoga and mindful suite, as well as the mind labs, where we are following the traditional as well as the modern way using the computerized models of assessment and therapy.
Welcome to the Neurodiagnostics Lab. So this suite is well equipped to run all our electrophysiological assessments. So here we do the EEG, the nerve conduction studies. We also run the autonomic tests. And here you can see the tilt table, which is used to do part of the autonomic testing. This suite also has a state-of-the-art sleep lab. It's a very comfortable space where patients with sleep disorders have an overnight polysomnography, that is the sleep study. So you can see that this is a suite which is very well equipped to run all the neurodiagnostic tests for patients with neuropsychiatric disorders across the lifespan. Welcome to our advanced gym facility on the rehab floor. Here we have equipment which is customized to address physical disabilities for patients with Parkinson's disease, for stroke, for traumatic brain injuries and various other neurological disorders which cause a lot of distressing physical disabilities. These are our mobility lab suites, a part of the rehab floor. And here our well-trained and expert physical therapists deliver interventions such as electrotherapy, manual therapy and exercise therapy for patients with pain, balance and posture issues and autonomic symptoms, among various other physical symptoms of neurological disorders. This is our Dr. Deepa Krishnan Neurodevelopmental Therapy Suite, and here our physical therapists work with children with neurodevelopmental delays. On the rehab floor, we have the speech and language therapy suite, where our speech and language pathologist delivers speech interventions and swallowing maneuvers to children, adults and elders with speech and swallowing disorders. The second floor is dedicated to holistic care. So we have the complementary and alternative medical treatments. So here we have 2 dry therapy suites where we do acupressure, reflexology and meridian massage. And here we have 3 wet therapy suites where we do treatments with medicated oils, powders, with foments, and we use mud packs, after which the patient can go across to the bathroom and have a bath. And these treatments are used for a host of physical, cognitive and behavioral symptoms which are very common in neuropsychiatric disorders.
Thank you and welcome and good morning. I'm just going to share screen as part of saying the formal welcome. So it's our 15th anniversary today at Buddhi Clinic, and we cordially welcome everyone who's present both online and offline. As Cyclone Fangel, I understand is how we pronounce it, progresses, leaving a trail of destruction. I think it's important that we remember the many people whose lives have been affected by this natural calamity, and also pay tribute to all those who are working so hard in the field and in the communities to help those who are affected. So while we have managed to resurrect our live event into this webinar, I think it's very important that we are mindful of the very, very difficult circumstances in which we are in. Our 15th anniversary, as always, coincides with the International Day for People with Disabilities, which actually falls on the 3rd of December each year. And we pay tribute also to those several million people around the world who have either developmental or acquired disabilities that have impacted on their ability to achieve their potential. The theme this year is amplifying the leadership of persons with disability for an inclusive and sustainable future. And I think the Buddhi Clinic agenda of focusing on disorders of brain, spine, and mind, which are among the most disabling, and to work with people to restore, rehabilitate, and make them well is very, very appropriate, because our work is totally focused on helping people achieve their human potential. And please, let's not forget that deep within each one of us is a contributor striving to get out and make a mark. As Steve Jobs would have said, every one of us can put a ding in the universe. It's just being able to achieve our potential. I'd like to welcome specially our keynote speaker for the day, my good friend, Dr. Nagaendran Kandiah, Associate Professor of Neuroscience and Mental Health at Nanyang Technological University, Singapore, and Senior Consultant Neurologist at the National University Hospital, Singapore. He serves as Director of the Dementia Research Centre in Singapore and Co-Director of the LKC Neuroscience Program. He's going to talk to us about the cutting edge of Alzheimer's disease from diagnosis to treatment. He's a senior clinician scientist with the National Medical Research Council Singapore, with special interests in fluid biomarkers and neuroimaging of cognitive disorders. He has secured over USD 20 million in research grants and has published in excess of 175 peer-reviewed scientific papers. Dr. Kandiah, it's a great pleasure and an honor to have you join us today. And
Thank you, Krish.
for taking all the trouble to be here.
My pleasure being here.
Thank you. We welcome our Honourable Guest Dr. Nirmala Lakshman, publisher and Chairperson of The Hindu, also a very good and old friend of mine. But I celebrate her most for being founder and curator of The Hindu Lit for Life, which enthralls all those of us who are interested in the written word annually.
Thank you very much. Thank you so much, Dr. Krishnamoorthy, for your kind words.
I'd like to also welcome our co-host, Professor Mohanasankar Sivaprakasam, Director of the Sudha Gopalakrishnan Brain Centre in IIT Madras, who readily agreed to co-host this event.
And, if you are not already familiar with the work of the Sudha Gopalakrishnan Centre, it is a must-visit place because of the very, very high quality of cutting-edge research that's going on. Vivek Mishra, our Director of Neurosciences and Innovation, will be making a presentation on the bouquet of innovations that in Buddhi Clinic we bring together. And so I would like to welcome him to do that. Thanks to everyone in this audience. Many had intended to be personally present at the IIT Madras Research Park. And you see our Buddhi Clinic team, which actually has assembled there today. And thanks to everyone who shifted to being in the webinar. We'd like to thank those who always intended to be online with us. And welcome all of you. We especially thank our honorable guest, our keynote speaker, co-host, and event organizers, all of whom have accommodated the many shifts and changes brought on by the cyclone and are firmly with us today. We welcome the entire Buddhi Clinic team from across 5 centers, Ennapadam and Apollo Buddhi OMR, Buddhi at Ramakrishna Hospital, Coimbatore, Buddhi at Swami Dayananda Kripa Care, Sri Perumbudur, and the newest kid on the block, Buddhi Clinic, the Apollo Buddhi Rehab Center in Indore. So welcome to the entire team. Just very briefly, at Buddhi, we worked to make the case for harmony, that traditional systems and modern science must work together in the interest of the patient and to help people achieve their potential. We include a whole host of treatments. Even I've lost count, but I believe it is now 19 different treatments that are available in Buddhi Clinic, including about 10 different new technologies that we use in helping people. But of course, the human element, psychological therapy, physical and occupational therapy, speech therapy, acupressure, acupuncture, reflexology, Ayurveda, naturopathy, and yoga, along with Tai Chi and mindfulness, the whole suite of treatments makes a huge difference to people who are working on their neurological or mental health disability. The key to a lot of this work is our team. Our team consists of doctors, of psychologists, of physical, occupational, and speech therapists. It consists of Ayurveda, Ayush professionals, and therapy technicians and healers. So it's a wide team of people who are working together with a common goal. We work across the lifespan, and I think the difference that we are making is in 360-degree diagnosis, a multidisciplinary approach, holistic impact, and most importantly, in the continuous tracking of therapy outcomes. We are able to show how people improve by tracking outcome measures clinically. It's been a long journey, a very organic one over 19 years. We mark our start as 2009 when we set up our first integrative health center, although we were a neuropsychiatry practice for much before that. And of course, Buddhi Clinic itself came into being as a single specialty model of care in 2017. So from integrative health to a blend of modern science and ancient wisdom with high quality rehabilitation. It's been quite a journey, and we keep adding new technologies. Even as of last month, we've added 2 new technologies to our armamentarium. Our numbers on their own speak a lot of volumes, and as you can see, we've served clients from 24 Indian states and 18 countries from across the world. And we have a very large database of people with whom we have worked, with some of our clients being very, very, very long-standing. It's been a great privilege for us. Our people are our foundation, so I'd like to pay a special welcome to the Buddhi Clinic team, many of whom who have contributed their thoughts to our cerebral musings, which you will receive a copy of. And I'd like to end by saying namaste. My soul greets your soul, and we are one, which is the traditional way of greeting each other in India. Welcome, and welcome to one and all to this program, and thank you very much. May I invite Dr. Nirmala Lakshman to give us her address.
Good morning, Dr. E.S. Krishnamoorthy, founder and CEO of Buddhi Clinic, honorable fellow guests, Professor Mohanasankar Sivaprakasam, Mr. Vivek Mishra, Professor Nagaendran Kandiah, and the wonderful team of doctors, clinicians, and practitioners at the Buddhi Clinic. I'm really honored to be here this morning and participate in the 15th anniversary celebrations of the Buddhi Clinic. And thank you very much for this privilege and the opportunity. I joined Dr. E.S. Krishnamoorthy in conveying my concern and sympathies for those whose lives have been severely disrupted by the cyclone yesterday. And I'm sure we will all do our best to contribute to get people up and keep people going, especially a place as precious as Buddhi Clinic, I think will be available to assist people who have been suffering in the storm. Today, we are marking the International Day for People with Disabilities and the 15th anniversary of Buddhi Clinic's service to humanity. Buddhi Clinic is set up by Dr. E.S. Krishnamoorthy, a multidisciplinary institution dealing with brain and mind care, has become the city's go-to place for a treatment of a variety of neuropsychiatric disorders for patients of all ages. What is remarkable is that not only does Buddhi Clinic deal with people of all ages and multiple neurological conditions, it offers a preventative care, early diagnosis, and a balanced multidisciplinary approach in clinical care, which I think is at the forefront of medical practice today. With his own advanced training and brilliant educational credentials in the field of neuropsychiatry, Dr. Krishnamoorthy and his team have embraced an integrative approach. We just heard a little bit about it, and taking on board valuable ancient traditions and combining them with a modern scientific approach. This has resulted in the astounding success of Buddhi Clinic, bringing sound, safe treatment, relief, and healing to thousands of people in the city as well as across the state, and I understand across other parts of India as well. Importantly, the 2024 theme for the International Day of Persons with Disabilities, which is being marked today, is about amplifying the leadership of persons with disabilities for an inclusive and sustainable future. The leadership of persons with disabilities is epitomized by the Global Disability Rights Movement, their slogan, which says, "Nothing about us without us." It connotes the basic requirements of participation, representation, and inclusion, and calls for persons with disabilities to actively shape the conditions of their lives. A new paradigm has been put in place in recent years, which recognizes the importance of subject measures to ensure success. And I think this has been recognized by many global bodies and local bodies, where the participation of the subject is very important to ensure the success of any program across multidiscipline areas. One of the priorities of the Global Disability Agenda is to advance the agency and leadership of persons with disabilities. In the past decades, persons with disabilities and organizations of persons with disabilities have been leading many of the community-led initiatives, not only to advance their own rights and well-being, but also to promote inclusive development. It becomes meaningless unless the people themselves are involved. When we think of disability, we often focus on the developmental disabilities and on physical disability. While no doubt these are important and deserving of our full attention as a society, we should not at the same time forget to focus on the specter of acquired neurological and mental health disability, which I think the Buddhi Clinic has beautifully integrated into its program. Strokes, traumatic brain injury, poorly managed or untreated epilepsy, and neurodegenerative disorders like Parkinson's disease and Alzheimer's dementia are some of the most disabling conditions in the world and appear on the top 10 list of disabling conditions identified by the World Health Organization. These disorders strike young adults and middle-aged people who have the potential to contribute to their communities, rendering them disabled and dependent on their families and fellow men. In all these conditions, damage to the brain due to injury or degeneration leads to a range of neuropsychiatric problems, mobility, memory, and mental health of all being affected. Of all the neurodegenerative conditions, Alzheimer's disease is among the most disabling, and we are hearing more and more about it as with each passing day. While it typically presents in older persons, The risk of increasing with age, the seeds for its development are laid down much earlier in life with diet, sleep, lifestyle, pre-existing educational attainment or lack of it being clearly identified as risk factors. We're hoping to hear more from the experts on this today. Today, we also understand that diabetes, hypertension, smoking, excessive alcohol intake are risk factors for the development of dementia, as it's nutrition, as is nutrition. In this lecture, Professor Nagaendran Kandiah, a leading researcher in the field based in Singapore, will outline the cutting edge of knowledge in Alzheimer's disease, from diagnosis to treatment with new monoclonal antibodies. We are looking forward very much to hearing from you, sir. And as I mentioned earlier, I'm very happy to note that Buddhi Clinic has made significant strides in the treatment of neurological and mental health disability over the past 15 years. And what started as a concept of integrative healthcare is an expanding enterprise with an evolving chain of in-hospital centers, taking the efforts to the mainstream. I'm also very happy to note that Buddhi Clinic has in recent times expanded its footprint outside Tamil Nadu to Indore in central India, opening a first of its kind comprehensive rehabilitation facility together with Apollo hospitals. And while have been very happy to see the social impact efforts of Buddhi Clinic bear fruit year upon year, it gives me great pleasure to note that via the development of an offline to online platform, Buddhi Online, the first rural Buddhi Seva Center established by Buddhi Clinic, will soon be open in Odanchattiram. I must conclude by congratulating everyone at Buddhi Clinic for a remarkable 15 years. We are all aware that the spirit behind the team at Buddhi and the remarkable group of health practitioners is Dr. Krishnamoorthy, whose brilliant, passionate, visionary, and inspirational leadership has made the institution what it is today. His contribution to the mental and physical upliftment of many has been noteworthy and excellent. In that, he has followed the great example set by his father, the pioneering neurophysician Dr. Krishnamoorthy Sriniwas, who contributed so much to the enhancement of public mental health in the country. We have had the privilege to know 2 generations of this wonderful family and all their talented contributions to the country and to society. Keeping in mind the need to expand the horizon of medical knowledge to the ordinary person, Dr. E.S. Krishnamoorthy, who is a great communicator, has persistently also conveyed specialized information to the lay public in an accessible manner. In this regard, I'm pleased to say that the Hindu has partnered him many times as a platform to showcase his very important ideas. Having also personally witnessed the great impact of Dr. Krishnamoorthy's care and treatment at many levels with people whom I know, I would like to acknowledge and salute his humanity, his expertise, and his deep commitment to improving healthcare outcomes across the country, especially mental health care. Thank you once again for giving me the privilege of being here this online, though it is. We are very happy that it actually happened, and I wish the Buddhi Clinic many more decades of excellent work in the field of mental health. I look forward to hearing from all the other experts. Thank you very much.
Thank you very much, Dr. Nirmala Lakshman, for those very, very generous words of encouragement and support. Wonderful to have you here. I have great pleasure in inviting Professor Mohansankar to tell us about the lovely work that they are doing at the IIT Madras Sudha Gopalakrishnan Brain Centre. Professor Mohansankar.
Thank you. Thank you very much. If you can hear me.
Yes.
Yeah. Okay. So, I mean, I really would have liked this to be physical, but, given this is probably the best. And I'm very glad in one way, half of you are physical, which is where probably we would have met you. So this particular work and sort of the effort and enterprise I'm sharing with you may actually come as a surprise to quite a few people. I wouldn't believe that this work is happening right here in Chennai and in India. And there are reasons why, it's probably flown under the radar. First of which is this work started during the COVID period. It's around 2020, literally just a few weeks before the lockdown. And the entire technology platform, which I'm going to share with you, was developed during the COVID period. And as a result, it probably didn't come out in a significant way. And second is, well, many of you know, I mean, Chennai has this peculiar habit of keeping its, all the good news very quiet, right? But somehow it has this culture, and probably that has contributed to it as well, I should say. But anyway, here we are. So this work is actually truly a sort of a global league. Right? So we are essentially imaging the human brain at cellular resolution, right? Which is, one of the largest challenges, probably like at the level of space, universe, and gene, which was reasonably cracked over the last few decades, is to see what is really inside the brain physically. Right? And that has not happened because of the sheer complexity. And the brain is also inside a very safe skull. So if you want to see the brain today, you can see at the best at a millimeter level, right? Through MRI. And if you look at the kind of complexity that's there in the brain, we probably have to get to the level of few microns, if not smaller. So this has been a challenge over the last 30, 40 years after MRI has been developed and became clinically commercial in 80s. We have not really made any major, advancement in terms of seeing the brain at any particular detail. So this work started about 4 years ago. And what we're doing is we are creating detailed maps of human brains across the age groups, starting from 12 gestational week fetus all the way to 100, 120-year-old brains, right? Across age groups, across pathologies, infections, neurodegenerative conditions. And all this, you probably quickly figured that, this cannot happen unless you have really an advanced technology that can do this at a high throughput, right? Because, if you want to image the brain at micrometer level, the entire brain, you really need to do this at certain speed so that you can do all this in a reasonable time frame to make a contribution. So, and this work really happened through a series of things, and it will be good for you to actually be aware of it. Our group at IIT Madras, which is almost 15 years, has been working on various healthcare technologies. And that's a separate talk by itself. And people who are in the research park, it's the same building where this work happens. And these technologies till date have reached about 12 million patients, both in India and abroad, in various fields, ophthalmology, patient monitoring, maternal and child health, endoscopy, and all that. And about 2014, our alumnus, Sudha Gopalakrishnan, who many of you know, a co-founder of Infosys, he wanted to do something significantly at brain research at IIT Madras. And, we started having this conversation. In about 2018, we said we will do something very, very ambitious, a very high risk, high reward type of deep science and high tech, driven by high tech project. And we looked around and we said, we'll pick a challenge, which was, really a tough challenge, which is to image the whole human brain at cellular resolution. And then it took 2 years to put this plan together. And the Office of Principal Scientific Advisor, which is essentially a PM Scientific Advisor's office, came forward. And then we started this project. And now you probably understand why everything happened during 2020. The project was sanctioned in 2020, and in 3 weeks, there was a lockdown. Right? So this entire project was done during the COVID period, building this technology. And today, this center is truly a world-renowned center. It has brought together close to 150 neuroscientists, engineers, various clinicians. And what we are doing is essentially, can be sort of encapsulated by this statement that was made about 30 years ago by Francis Crick, who discovered the double helix DNA structure, who essentially said, until we get new techniques, we will not be able to see the human brain in great detail. And it's interesting that he made the statement about 30 years ago, and it's still true today. Right? There is no practical way to image the whole human brain, even if you take a postmortem human brain, you can't image it. The reason is you essentially need a telescopic microscope, if I can call it, right? Because we can do imaging of human brain at cellular resolution in small areas, right? I can take pieces of the brain and do it. I can do whole human brain imaging at millimeter level using MRI or CT. But if I want to do micrometer level imaging, but of the entire brain, which is about 1.5 liters, right? Then I really need a new technology platform that will slice this brain at very, very fine sections. And I mean, anytime you section something very thin but very large, it becomes a very difficult physical problem to handle. Right? Like the way you cut any vegetable in a kitchen, when you cut something thin, when it's large and thin, it collapses. Okay? So essentially, this work, if you look at it, today, the state of the art is it can be done on mouse brains, right? And it has been tried in monkey brains, but nobody has really done this at large scale on human brains. So we sort of decided that, we won't take the path of doing it in mouse, then monkeys. So we took a big risk that we will do it directly at humans. And today, we are successful. And as a result, and India is probably the first country to be able to do this at very large scale. Now, how do we do this? And this ideally, it should be a physical visit. And, I'll be happy to host anybody who wants to visit this center. This platform, which you see, which is sort of depicted as a workflow here, is about a large 6,000 square feet R&D center, which takes in a human brain post-mortem within about 6 to 8 hours, maximum 12 hours after death. And then a series of processes are done to it to essentially fixate the brain. Some of you may be aware of this. Then we freeze the brain at minus 80 degrees Celsius. Right? And then we subject it to a series of processes, which is completely automated and robotic control system, which cuts the brain at 10 to 20 micron sections. Right? So which will be about 10,000 sections if it's an adult brain, about 2,000 to 4,000 sections if it's a fetal brain. And then this very thin sections are picked up by a very complicated process, which we have simplified so that it can be automated at scale. And then they are laid out on a series of glass slides, essentially how you will do histology. And then these are imaged, and you probably have realized that these are very, very large sections, right? So about 15 by 20 centimeter. So microscopy generally is always done on small sections, few millimeter by few millimeter, maybe few centimeter. Now, the moment you have 15 centimeter by 20 centimeter sections, you essentially need a new set of microscopes. Essentially, that's why I always say that it's like a telescopic microscope, right? I want to be able to microscopically image the entire 15 by 20 centimeter in preferably less than 1 hour, because I can't wait for a day to do this, then we will never be able to attain the scale. So we developed these microscopes in collaboration with the industry, and today we have the largest throughput whole brain imaging facility in the world. We are able to process an entire human brain in less than a month, right? And that's the fastest that you will see in the world. And as a result of that, today we have close to 220 brains that are acquired from various medical institutions in the country and abroad. And I mean, this is to give you a sense of the size and volume. Right? Ranges from 10 to 20 cc, which is about a second trimester, early second trimester fetal brain, all the way to this is a young adult, and sort of a full-blown adult gets you to close to 1,300, 1,400 cc brain. So with all this, we are able to do a serial section histology of the entire brain and do a microscopy of that. And now comes the most difficult part. Now that you have done all this, you have hundreds of terabytes of data and petabytes of data. Now you have to put it back together. Right? Because that's when you can actually see the whole 3D brain. And I'm very pleased to sort of share with you, and what you're seeing is actually the world's first 3D assembled fetal brain data. And of course, we're doing this for various age groups. We're doing it for adult, and I'm showing one here. And we are sort of very proud to say that typically when scientists do this kind of work, they usually don't release this data. It is considered as a competitive edge. You sort of keep this data to yourself. But this data is going to be released publicly, right? Where anybody can access this data at cellular resolution. And it's going to be made available globally to anybody in the world. And this is going to happen in the next few weeks. In fact, this publication has been accepted. So in summary, I would sort of say that we have processed close to 70 brains, ranging from fetus to adult, ischemia, neurodegeneration, and neurotypical brains. And our goal is we want to create this primary ground truth, which is what is not available today, to advance disease diagnosis and treatment. And how does this happen? We work with, of course, neurobiologists to annotate this data, get into the details. Then we work with clinicians to correlate clinical findings which we have of certain brains and MRI and overlay that on this deep, high-resolution scientific data. Dr. ESK put it very nicely. I mean, this kind of effort and this kind of work happens only if we collaborate and work together. And close to almost 150 and maybe close to 200 today, different experts from different parts of the medicine, and these are all spread out across geography, both in India and outside India. And together, all of this has, really has attracted the best in the world to come and work with us. And we are at a point where we can say that over the next couple of years, we will be able to do analytics, meaning you could potentially ask the question, what is the glia density in hippocampus in, let's say, a neurodegenerative condition compared to a neurotypical of the same age or compared to a different type of a brain. So we are creating this large computing platform which can query this kind of data and make it available. Something very interesting has happened. This is a good question for all of us. We always ask, how many cells in the brain? And usually we give a general answer based on some estimation. We are probably the first in the world to answer that question, and this work is going on as we are speaking. We are able to physically count each cell across the brain regions and say this region has this many cells. And this is this has huge implication in terms of both scientific advancement as well as answering many questions towards developing therapeutics. So this is really what we are doing, which is we are advancing detailed images of the brain from MRI to cellular to chemical. And in some cases, we are even doing molecular level detailed analysis of protein expressions. And all this essentially is driven by something which we all are passionate about, is to advance diagnosis and treatment of brain diseases. So I will sort of stop there, and I look forward to sort of hosting many of you, especially people in Chennai. Just come by to the Brain Center, and we'll be happy to show this physically around. And once again, thank you, and we can take some questions towards the later part of the session. Thank you.
Thank you, Professor Mohanasankar, for sharing the wonderful work that is being done at the IIT Madras Research Park, at IIT Madras, the Sudha Gopalakrishnan Center and the Research Park. Request you to stop sharing so we go back to the main screen. Thank you. We've now heard a little bit about, post-mortem or, in pathology, how things look like. But of course, all of us are very concerned about what can we do when a person has dementia and or any other degenerative or developmental disabling condition. And to present the cutting edge of rehabilitation technology, very briefly, I'm inviting Vivek Mishra to share his screen and tell us about all the new equipment that has come together today to help people with neurological and mental health disease. If you're wondering, it's a little bit like a concert. You're getting all the tukdas before you hear the main speaker. So seek your patience.
Okay, so good morning, everyone. I think my slides are visible.
Yes.
As we all assembled here and also celebrate or put a focus on the International Day for People with Epilepsy, I just wanted to highlight that when we celebrate the International Day of Persons with Disability, this is just October, the data is published, that there are estimated 1.3 billion people experience significant disability. And this represents 16% of whole world population. It's 1 in 6 of us. But not all disabilities are visible. And of course, we are looking at those findings on a daily basis. So what is an invisible disability? Is described by the Invisible Disability Association that any form of impairment in physical, mental, and neurological condition that is not visible from outside, which can limit the challenge and challenge a person's movement, senses, and activity. So this invisible mental health disability are just as real and debilitating as the physical one. Even they are most not immediately recognizable. Conditions such as depression and anxiety, migraine, schizophrenia, epilepsy, they are all invisible. And of course, there are many other. So to put in perspective that just now what Professor Mohanasankar was showing, that how our brain coordinates, but our brain is just like an orchestra, complex networks of neurons, what we just saw, which conducts the music through of thoughts, emotion, and actions. And when this symphony gets out of tune, the behavioral, psychiatric, and neurological condition arises. For example, depression, anxiety, and even the neurological phenomenon like seizures. So what is the current challenge? The current challenges are the medication and therapy are valuable. But for example, 30 to 40% of people with OCD or up to 60% people with depression fall under treatment resistant or refractory, where no medication helps. The side effects are limited and have limited efficacy, can hinder the adherence to the treatment. So what to do next? Looking at the lens from the symptoms to substrate, we can make the invisible visible while highlighting the brain networks which are not functioning well or affected by a particular disorder. And how we are able to do is just by using the non-invasive brain stimulation, which act on a single principle of brain plasticity. The ability to change and adapt the brain continuously through our lifespan is what the neuroplasticity is. And the non-invasive brain stimulation harness this neuroplasticity for the therapeutic purposes. So our journey started from understanding the brain to the training at Rambam Healthcare Center in Haifa, Israel, and then acquiring our first TMS machine when we got in 2018. And over the years, we have delivered over 19,600 individual sessions using the non-invasive brain stimulation methods. And one of the major modality what we use is the transcranial magnetic stimulation. It uses the magnetic flux to stimulate the particular brain regions. And how it does is it's causing the depolarization and firing of the local neurons. We use multiple TMS pulses in a chosen brain region at a frequency which typically varies from 0.5 Hertz to 20 Hertz. And when TMS sessions are adjunct with cognitive behavioral therapy, we can prime the brain to be more responsive and reduction in symptoms more effectively. Just to give an diagram that based on hardcore physics of Faraday principle, the rapidly fluctuating magnetic field is being generated, which induces the current underlying cortex and permit focal manipulation of the cortical activities. As I said, there are different waveforms which we can employ. And these waveforms can give us a physiological effect. For example, when we talk about in depression and we see repeated trials can enhance the cerebral blood flow in the particular brain area which we are able to stimulate. Similarly, a lower frequency can inhibit the brain regions. on the targeted areas what we look for example, in OCD. And just to put a perspective that it is not an electric shock, but just a painlessly delivered thing. And you can see that there are just the girl who is taking the TMS. Okay, I think, okay. So, and she is able to talk while the treatment is being delivered. So it's just use a magnetic coil on the forehead. When we talk about the implications of these networks with the use of TMS, we can look for the patients with OCD. We are looking for patients with schizophrenia and OCD, which is a schizo-obsessive complex disorder, what we can able to stimulate, or I will say the manipulate those brain regions which are affected. And one of the newer diagnoses, what we have running also a trial with the patients of stimulating the precuneus magnetic stimulation for the Alzheimer's disease. And it is just published this year in journal Brain, which have found some very promising data to evaluate the cognitive outcomes. Another modality what we use is TDCS. TDCS uses the weak electrical stimulus to modulate the brain activities in specific areas. Now the TMS can't go to the bedside in ward or at home. However, the TDCS we can able to deliver the treatment at the bedside and also at home. In fact, we can use for treatment of depression, anxiety, mild cognitive impairment, speech and motor related conditions like multiple sclerosis, stroke, even Parkinson's, while stimulating their motor cortex. Again, there are multiple waveforms what we can use to depolarize or hyperpolarize the brain networks. And again, based on the deep science that where we place the anodal stimulation, it goes in excitatory mode and the other regions goes inhibitory to bring the balance back, but not one size fits all. We can see that the psychotherapeutic interventions can adjunct the TDCS treatment. For example, this kid with ADHD undergoing the TDCS while focusing on the task. And for each of the disorder, it's like a personalized approach. So even if we take an example of ADHD, is it inattentive or impulsive or combined? We can choose the treatment paradigms which are more beneficial for the patients. TAVNS, it's the transcutaneous auricular vagus nerve stimulation. It stimulates the auricular branch, as you see in the photograph, that just one electrode. So we use the device from Sotrix Medicals US, which patented this technique of stimulating the auricular branch of the vagus nerve. And the recent expansion in the use of VNS applications, because it can do, so previously it was an implant, and now we can able to stimulate the vagus nerve from the outside, and there is an opportunity for novel use in healthy population, especially regulating the gut-brain axis. And again, the data, strong data coming from the various electrophysiological studies which match the implant VNS versus the TVNS and combine the vagus nerve VNS being used increasingly in the treatment for conditions like epilepsy, depression, and chronic inflammation as an adjunct to rehabilitation, for example, in upper limb recovery, in post-stroke rehab, and also a technique for the cognitive enhancement. Last year, we did inducted the neurofeedback, a QEEG guided neurofeedback therapy, monitors your brain for the brainwave activity and almost immediately provides a feedback, which often through visual and audio cues. So neurofeedback, again, if we just go look back the QEEG data, we can find can be helpful in children with ADHD, anxiety and depression, and in some cases of drug addiction, schizophrenia, and learning disability. When we talk about stimulating the brain and spine, the another avenue which comes to our mind, but why not muscles and nerves? And the FMS at all our Buddhi centers produces roughly 3 Tesla of magnetic flux, which can be used to modulate the nerve and the muscle groups to elevate the symptoms of pain. The implications are also in spinal cord injury, upper and lower back pain, fibromyalgia, neuropathies, and some cases of urinary incontinence resulting from the injury. And this is the most recent technology, what we have just inducted in our Indore is the IFS, Integrated Functional Electrical Stimulation, SMG and the EMG based devices for the post-stroke rehabilitation. Also the spinal cord injury patients can undergo these modalities. And there is an evidence and success stories from the post-stroke rehab to as new as the treatment of a post-acute sequelae of COVID-19, what is termed now as PASS with the TAVNS. To conclude, so by understanding the underpinnings of the brain and mind disorders, we can target specific brain regions to enhance the recovery, even in intractable cases. And recovery is multifold when adjunct with the integrative therapy approaches composed of clinical psychology, physiotherapy, holistic care, and of course, optimized pharmacotherapy. So I will stop with this and we will see. Thank you.
Thank you so much, Vivek, for taking us through the cutting edge of neurorehabilitation using non-invasive brain stimulation. After all those presentations, we now come to the keynote lecture by Professor Nagaendran Kandiah, The Promise of Biomarkers and Disease-Modifying Agents in Alzheimer's Disease, which promises to be an extremely interesting topic, and I'm sure he will enthrall us over the next 40 minutes. Professor Kandiah. You're muted. Yeah, Prof, you're muted.
Okay, can you hear me now?
Yes, thank you.
Okay, firstly, good morning, everyone. I want to thank Dr. Krishnamoorthy for having me to be part of this important and exciting event. I also want to congratulate Buddhi Clinic. I think they are doing so much of good work, helping your patients, providing that holistic integrative care under one roof. So over the next 30 minutes, what I hope to do is to tell you about the promise of biomarkers and disease-modifying agents in Alzheimer's disease. And the topics that I will cover will include the spectrum and trajectory of cognitive disorders, the pathobiology of Alzheimer's disease, current and new biomarkers for Alzheimer's disease, as well as how can we then prevent and manage Alzheimer's disease. In this figure, you'll see that there are two curves. The green curve is one where those of us who are lucky, where we don't develop any brain disease, we experience normal aging. Even with normal aging, you will see that there is some decline in cognition. This is what we call as an inefficiency in cognitive processes, where one may take a little longer to complete a task, but he or she still can complete that task. The impairment is minimal. The person often can function quite independently. However, for those of us who are unfortunate and develop brain diseases such as Alzheimer's disease, then we can look into this as three different phases. The first phase is what we call as a preclinical phase. This is a phase where there might be no overt symptoms, but there are already brain changes happening. And you'll see here the MRI scan largely looks quite normal. And I'll talk more about this. The second phase is the phase of mild cognitive impairment. Again, where there are some symptoms, there are already some structural changes in the brain, but function is still intact. And lastly, you have the stage of dementia, where brain neurodegeneration has taken to a certain extent, quite an extensive extent, in fact, and symptoms are impaired as well as function being impaired. So this is the entire trajectory of what happens with aging. So as I shared earlier, this cognitive continuum starts from normal aging to what we call a subjective cognitive decline, where there may be some symptoms, but no objective deficits. Then you have the stage of mild cognitive impairment, where you have symptoms, some objective deficits on a test, but function is still intact. And then you have the stage of dementia, where function becomes impaired. And this is important because if you look at the risk of progression, if one is say 65 years old, but no brain disease, then the risk of that person developing dementia is less than 1% a year. However, if you have a patient who has subjective cognitive decline, there be some symptoms, then this risk increases to about 3% a year. While if you have a patient who has mild cognitive impairment, meaning there are symptoms, and when you do an objective test, there are already some impairment, this risk is high. It's about 12% a year. So what we really want to do is to try and detect people at the very earliest stages so that we can start rehabilitation, start management to reduce the progression to dementia. So as I said earlier, you have the preclinical stage, the mild cognitive impairment stage, which usually progresses to dementia over a 3 to 5 year period, and then you have the dementia stage. Now, this is what we refer to as the iceberg phenomenon. I think all over the world, when we see patients with dementia, that only represents the tip of the iceberg. What is beneath the surface are hundreds and hundreds of, if not millions of patients with mild cognitive impairment or preclinical stage who will be developing dementia over the coming years. So this is what we really want to prevent. So a bit more on mild cognitive impairment. Right? So this is relatively a new phenomenon, has been there for about 2 to 3 decades now, but getting more importance now because there are new medications that target mild cognitive impairment. So what is mild cognitive impairment, or MCI? It's one where the person is not normal for age, at the same time does not meet criteria for dementia. There is some cognitive decline, but otherwise the function is essentially normal. There are two main types. You have the amnestic MCI and the non-amnestic MCI. Amnestic MCI is where the symptoms are largely of forgetfulness, whereas non-amnestic could be non-memory issues, for example, wayfinding difficult. Within each of these, you have the single domain and multi-domain. Now, it's important to differentiate whether the patient in front of you has amnestic or non-amnestic MCI, because if you look at the trajectory, patients with amnestic MCI almost always progress to Alzheimer's disease, while those who have a non-amnestic type may have other forms of dementia down the road. This may include vascular dementia, Parkinson's disease dementia, or even just a psychiatric disease without any neurodegeneration. So these are the trajectory that we could project. Now, I think diagnosing someone at the later stages of dementia is not so difficult. But what is challenging is how do we then detect someone at an earlier stage? And I would like to look at it from 3 different spheres. The first sphere is the cognitive sphere, where you have someone who comes and tells you that, doctor, I'm not as good as how I was 3 years ago. I know that I've declined, right? That's what we call as an intra-individual change. There could be some minor errors at work, problem or challenges with more complex tasks, for example, investments or taxes. So very, very subtle symptoms. Then you must also remember there could be mood changes, poor motivation, emotional dysregulation, impulse discontrol. So again, this could be early presentation. And now we have a term for this called mild behavioral impairment, which is again something that we are beginning to see quite extensively in the earlier stages. Now, the last sphere is the physical sphere, what we call as frailty, where the slowness of gait, reduced grip strength, a cautious gait. Again, this could be an early manifestation. Now, while these 3 arms, cognition, mood, and physical, are good, it's a good way to detect someone at an early stage. I think we also need to be mindful. We don't want to overdiagnose, right? Because the symptoms are quite common. And that is where the later part of my talk, focusing on biomarkers, how can we then use biomarkers to make sure that when we diagnose someone at a very early stage of MCI, we really know for sure that that person has a brain disease. And I'll touch more about that over the next few minutes. So in a table form, I think this is something that I want to make sure that we all understand, is that the differences, right? So you have a stage of normal where you have no symptoms. You have a stage of subjective cognitive impairment, as the name implies, only subjective symptoms without objective deficits. And then you have mild cognitive impairment, where you have symptoms, you have objective abnormality on cognitive testing, but your instrumental activities of daily living is still intact. Then you have mild dementia, where your instrumental activities are affected, but your basic activities are intact. And then you have the later stage of moderate to severe dementia, where even the basic activities like bathing, cleaning yourself, feeding, eating, and so on becomes affected. So this is the entire spectrum of cognitive syndromes. Now I want to introduce the concept of early dementia. We know that there is mild dementia. So what is early dementia? This is a term that has been used more frequently over the last 5 years, mainly because of the newer drug interventions. So this syndrome is a stage of disease where the irreversible neuronal damage or neurodegeneration is minimal, right? Functional-wise, still relatively intact, but there are treatments that could substantially alter the course of further decline. So early dementia, in practical terms, includes both stages of mild cognitive impairment and mild dementia, and there are now disease-modifying drugs targeting this stage of early dementia. So with that background, let's talk a bit more about the pathobiology of Alzheimer's disease. This is work that we published about 2 years ago from the Southeast Asian population. There are many different brain diseases that can result in cognitive impairment. But if you look at this pie chart, in 2/3 of the time, it's Alzheimer's disease, and then you have vascular disease, it's a close second. So these are the two main causes of cognitive impairment in globally, as well as in Asia. And I'll touch more about these two conditions. So firstly, you have the Alzheimer's disease pathobiology. So on this figure, you'll see MCI is already at the end of a long trajectory, right? Even then, after MCI, you still have dementia, the different stages of dementia. Now, in the pre-MCI stage, you have the preclinical stage. This is divided into stage 1, 2, and 3. In stage 1, you have amyloid deposition. So amyloid is crucial in the diagnostic or the biomarker diagnosis of Alzheimer's disease. This can be measured using a PET scan or a cerebrospinal fluid assessment. Stage 2, you have amyloid deposition plus some neurodegeneration. And stage 3, amyloid plus neurodegeneration plus some subtle cognitive decline. So these are the preclinical stages. So what we really want to do is to try and diagnose people at the very, very earliest stage. If not, if possible, MCI, but if we are able to move that curve more to the left, then I think then we'll be able to preserve more neurons down the road. Then a bit about vascular dementia. Again, quite prevalent in this part of the world, often in people with vascular risk factors, hypertension, hyperlipidemia, diabetes, and so on. What these risk factors do is they affect the blood vessels in the brain. They affect the small vessels, what we call as arteriolosclerosis, or they may affect the large vessels in the form of arteriosclerosis. In Asia, what we are seeing is actually the small vessel disease, which means that over time, this results in continuous brain damage, as we can see on this MRI, where you have these white lesions, which tells you that there is ischemic damage to the brain cells, and this then results in cognitive impairment like MCI. So work from Cliff Jack and also from the dominantly inherited Alzheimer's network study. On the x-axis, you'll see time point 0. That's when symptoms begin to appear. But what you'll appreciate is 30 years before that, there are already measurable brain changes. This is using CSF, using PET scans. So much of brain pathology is already accumulating. So what we really need to be doing is to be able to detect as early as possible so that we can reduce this increasing brain pathology. So with that, what are the biomarkers for early dementia and who should be evaluated, right? So I would use the word case finding rather than screening. So case finding would apply to people who are older, 65 years and above, those who have a family history of dementia. So some work from the center in Singapore, we're finding actually 1/3 of our patients who come to the center actually have some form of family history. So it is quite prevalent. Strokes. Again, work from Singapore has shown that if you had a stroke in the past, this is a major risk factor. You may have recovered physically, but your cognitive impairment is going to be progressive. And more common is those patients who have vascular risk factors such as diabetes, hypertension, hyperlipidemia, and so on. So when we see a patient, what do we ask them? We ask them for their cognitive symptoms. We look at it from different domains. Episodic memory. Are you forgetful? Are you misplacing your belongings? Do you remember what you had for dinner last night? Right? So personally experienced memory. Then we want to ask them about their attention span. Are they still able to follow a plot, for example? how is their executive function? So executive function here refers to anything that involves planning, sequencing, judgment, right? Visuospatial function, where we are talking about wayfinding. And of course, less commonly, you can also have changes in language, visual changes, and so on. From a behavior perspective, I think equally important, and I would like to group it. I know we have a very eminent psychiatrist here, but I would like to group it into frontal symptoms and psychotic symptoms. Frontal symptoms, because this could be in the early stages of disease, where you have interpersonal changes, behavior changes, changes in character, disinhibited, inappropriate behaviors, again, largely because of pathology in the frontal lobe. In the later stages of disease, then you have the psychotic symptoms. This may include delusions, hallucinations, agitations, and so on. So what are the tests available out there? There are many tests. I think most of us are familiar with the mini mental state examination, and I have left it out for a reason. MMSE is a great test. It's been there for decades. It is wonderful for the detection of moderate dementia, severe dementia. Unfortunately, not so useful in the milder stages because most patients get full marks. What I like to use is the Montreal Cognitive Assessment. It has been translated into many languages. It covers many domains that I spoke about. Executive function, visual-spatial function, memory is quite useful. There are problems with the MOCA, right? We could translate it, but when we translate it, you are also changing the inherent properties of the test. You're introducing cultural biases. So what we did was we developed a test in 2015 called the Visual Cognitive Assessment Test, or VCAT. This is more picture-based, figure-based, which means you do not need to translate it. One test, only the instructions change. This has now been accepted by the Alzheimer's Association, where we are now doing a large study in many parts of the world. In fact, some work with Krishnamoorthy in Chennai, plus many other countries in the world. So again, something to consider. We also have a community version, VCAT S, which only takes about 5 minutes. Want to be as useful as the main test. Again, something to consider in a population, community setting, or a primary care setting. So then comes the MRI. So at a clinic level, most of the time we use a visual read. And the structure that we're looking for is the hippocampus, what we see as medial temporal lobe atrophy. We look at the temporal horn, the interhemispheric fissure, the thickness of the hippocampus, and we assign a score. So this is useful when you pick up Alzheimer's disease at the amnestic form. But we also have patients who come to us with visual symptoms, right? What we call as posterior cortical atrophy. And here, the shrinkage is mainly in the parietal and the occipital regions. What has been now quite resulted in many new discoveries is the PET imaging using amyloid. And there are many traces. It started off with the Pittsburgh compound B. There are many more now fluorinated compounds with a longer half-life, allowing for more clinical use. So in Singapore, we used both the Pittsburgh compound B and the flutometamol, which allows us to quantify amyloid in the brain. And as I said earlier, to diagnose someone with Alzheimer's disease, you must demonstrate presence of amyloid. If you can't demonstrate the presence of amyloid one or the other way, then at best what you can say is this person has dementia of the Alzheimer's type, but not really being sure that this is Alzheimer's disease. So then comes the CSF markers. Quite an invasive test, quite a painful test, but there are also advantages because with a single test, you're able to measure amyloid, you're able to measure tau, and also studies have shown that changes in the CSF may actually precede changes on the PET scan. So it's a dynamic measure of amyloid. But what is really earth-shaking now is the blood-based biomarkers. I think for large countries like India, where we need to be able to measure amyloid in big numbers of patients, blood tests are most viable, most feasible, and there are many, and we have experienced with several of these, which I'll be talking about. The first one is neurofilament light chain. Basically, it's a cytoskeletal protein present in the myelinated axons, and studies have shown that as your cognitive impairment progresses, the levels are higher. It's a marker of neurodegeneration, but doesn't tell you more about pathology. So when I went back, we think back earlier about the symptoms I was talking about. So if someone comes to us at a very early stage, function is still intact, some forgetfulness, and you think that this person has MCI, if you are able to do a blood test measuring NFL, then you know that the underlying cause for that MCI is a neurodegenerative disease. So I think that is going to transform how we diagnose patients with MCI. Now, we also have now plasma measures of amyloid, both the A-beta 42/40, a lot of work has been done, and again, showing good correlation with the amyloid PET scan. What's new is the p-tau 181. This has been shown to be correlated with both the amyloid PET scan as well as the tau PET scan, again with an AUC of more than 90%. Now, the latest kid on the block, from a clinical perspective, there are many more under research, but from a clinical perspective, is p-tau 217. A lot of work has been done. We are doing quite a bit of research using p-tau 217. And you can see that in the graph, those who fall in the last quartile, the red line, their decline in cognition using the MMSC is so steep. Also, you'll see that there's great correlation between p-tau 217, both with amyloid PET scan at baseline, as well as increase in amyloid over time. So using p-tau 217, you'll know whether someone is having amyloid and what is the likelihood of them progressing in the short term. So a bit of work that is coming out from our center at the Biomarker and Cognitive Impairment Study in Singapore. So this was a study established about 3 years ago. The main objective was, we know so much about dementia, but most of this comes from the Western literature. How much of this is similar or dissimilar in the Asian brain? That was our main objective. So 5-year longitudinal study. We have now about close to 1,800 subjects already recruited. About 600 of them have come back for their year 2 evaluation. You'll see that almost everyone has some form of blood-based biomarker, because I really believe that is the way forward. A large number of them have 3 Tesla MRIs, also looking at the ASL, blood flow in the brain. So this is the study, the BioSys study. We do a full neuropsychological assessment. We do the MRI, we do the blood biomarkers, as well as now we have also included retinal imaging using a very high resolution scan, plus the microbiome work. So these are the numbers and some preliminary findings. So the graph on the left tells you about levels of amyloid, and this is all blood-based. Lower the 42/40 ratio means more amyloid in the brain. That would be the blue graph. And you can see that with greater levels of amyloid, every domain of cognition, episodic memory, executive function, visuospatial function, language, processing speed, all goes down. Now, graph on the right tells you about the STAL score, which is the measure of small vessel disease or cerebrovascular disease in the brain. And again, here the gray bars mean more small vessel disease. And you can see here again, the presence of small vessel disease affects every domain of cognition. What this really tells us is, in the Asian perspective, targeting amyloid is important, but we also need to target small vessel disease because this has a direct impact on cognitive outcomes. This is what the biomarker profile is looking at the moment from our study paper under review. Quite astonishing that it is quite different from the Western world. You can see that in the Western cohort, the red segment, amyloid is present in about 75 to 80%. The green segment, amyloid levels, the ApoE4 gene is about 40 to 50%. But compare that to our BioSys cohort, a Southeast Asian cohort, which I believe will be also quite similar to the Indian cohort, where the amyloid levels about 20%, ApoE4 18%, much lower. But what we are seeing a lot of is the brown segment, white matter disease in the brain, the purple segment, high burdens of white matter disease in the brain. So again, this really tells us that for the Asian setting, we need a different set of biomarkers. We need different interventions. So one thing that we have been doing is using all this robust data from the center, from the BioSys study, we are developing digital solutions. And we have now developed 3 digital solutions. The first one is for community level, where an individual in the community can do a simple digital game, and that tells them about their cognitive status. We call this the Realize app. The second one is the Recognize app. I'll tell you more about this. This is for healthcare setting. And we also now, once you diagnose, then what do? We have now developed the Revitalize app. Basically, it's a digitally based cognitive stimulation, lifestyle change, exercise, and so on. So the Recognize app is a gamified digital test, personalized, takes about 10 minutes. And what we have shown that the area under the curve is almost 0.9 when you compare to any traditional neuropsychological test for picking up MCI. So I believe that this is something useful because it's scalable. A lot of individuals out there, including patients in the clinics, can benefit from this. So how do we then make practical use of all these things that I've just shared about? I think we cannot run away from a good clinical interview. I think every doctor will do that. Then the next question that comes in is this patient having early dementia, like I spoke earlier? Is this early dementia here refers to MCI and mild dementia? Or is it not early anymore, moderate to severe dementia? And the test that can help differentiate that is a cognitive test. It may be a traditional pen and paper test like the MOCA or a digital test, because then we will know in which of these two conditions does the patient fall under. The next question is, I may have diagnosed early dementia. Am I sure that I'm dealing with a neurodegenerative cause? So is there an evidence of neurodegeneration? And here I believe simple MRI, you don't have to do a full sequences, just even the T1 sequence to show presence of medial temporal atrophy, or once the plasma NFL is available, that could tell us whether there's underlying neurodegeneration. Now, if your patient has a neurodegenerative cause, then if you really want to know whether this is due to Alzheimer's disease, then we need to show the presence of amyloid pathology. And here, a plasma test, a blood-based test, like a p-tau217, may do the trick. And once your patient unfortunately falls under this likely amyloid pathology, then you can confirm that with a more expensive or an invasive test, such as the amyloid PET scan or the CSF test. So this is how I would use these biomarkers to help our patients to make sure that we know whether this person has an underlying neurodegenerative cause and whether this is due to Alzheimer's disease. A few of us got together and wrote this review paper 2 years ago. For those of you who are interested to understand all the various aspects of biomarkers, this may be a good review paper to look into. So with that background, I'll spend the last few minutes talking to you about management of early dementia. And as I said earlier, biomarkers pathology is accumulating. We're not talking about age 65 anymore. We're talking about age maybe 40, 45, where there are already changes in the brain. And rightly so, all this while there's been a lot of focus on moderate to severe dementia. But what we really ought to be doing is move the curve to the left. Diagnose people at the MCI stage, mild dementia stage, because only then can you make a change to that individual. So the current practice, most of the time, most places in the world is we make the patient sees the doctor does a few tests, a cognitive test, blood test, a brain scan. Blood test is mainly for thyroid function, B12. They make a diagnosis. If it's MCI, he may be asked to do some lifestyle change, which is important. If dementia, then there are some medications that can be used to control symptoms. But the problem with this current system is, firstly, there's insufficient time in clinics. How do we do cognitive testing for so many patients? How about those who have just hypertension or previous stroke? We are not actively looking out for cognitive disease in these people. So we need to change this system. And I believe that's where digital solutions have a big role. I think in the community, digital solutions can enable self-evaluation, provide the right type of cognitive stimulation, provide support for lifestyle change. In the clinics, I think it can really fill in the gap to allow more cognitive testing for patients and also to allow prescription of cognitive stimulation, lifestyle activities. So the management of early dementia is multidisciplinary. It has to include non-pharmacological methods, like I spoke about. Firstly, you remove offending drugs. Your anticholinergic medications are often the culprit. Cognitive stimulation, lifestyle change. And then we talk about pharmacological. And here, I think optimization of vascular risk factors is so critical. We have now data from the Sprint Mind study, which showed that if you are able to reduce your systolic blood pressure below 120, then your outcomes in terms of MCI or combined MCI and dementia is significantly reduced. And I'll tell you more about the other drugs with the next few slides. I think the landmark study was the finger study. the Finnish study, 2-year randomized control trial, where they selected people 60 to 77 years, MMSE for about 26, and they had some vascular risk factors. Interventions include nutrition intervention, physical exercise, cognitive training, and critically vascular risk factor monitoring. And for the first time, they were able to show that with this type of a multi-domain intervention, you are able to slow down worsening of executive function, slow down worsening of processing speed, as well as reduce the decline in global cognition. So this was a landmark study, but the issue with this is how do we personalize it to different types of individuals? How do we scale it up? And this is where we have developed something called the Revitalize app, where you are able to personalize the intervention to the profile of the person and also allow them to have a more individual type and time to institute these cognitive exercises and lifestyle changes. We are now doing a study called the Demand Study, 6 Southeast Asian countries. We started about 6 months ago. Hope to have the final results end of 2025, and mainly looking at the feasibility of a digital intervention in the Asian setting. So from a drug perspective, the first drug I want to talk about is Fortocin Connect, also known as Sovanate. Those of us who remember the Kennedy cycle, a lot of the constituents of Sovanate is part of the Kennedy cycle, which is important for new neuronal membrane formation. And the landmark study was the lipid diet study. What the study showed was using Sovanate for up to 3 years resulted in less cognitive decline using the NTB score and also less hippocampal atrophy. So again, something that you may want to consider for your patients with early stage disease. The other one is EGB or ginkgo biloba. This is the thevenin version of it. And the mechanism of action here is it promotes microcirculation. And if you recall, in Asia, we have a lot of small vessel disease, and hence there is a role for thevenin. It also improves neuroplasticity, signal transmission at the synapse. This was their study, the GIMC Plus study, that showed that patients with MCI who took about 240 milligrams of EGB had better cognition, had better behavioral outcomes. And we in Asia formed a group to look at the real usefulness of EGB 761, and we came up with this consensus paper to show that EGB 761 has an important role in managing patients with MCI, especially if you think that the MCI is related to some form of vascular disease. So with that, the most exciting change in the dementia world has been the approval by US FDA of 2 disease-modifying drugs. One is lecanemab, is an antibody against amyloid beta, approved in early 2023. This lecanemab selectively targets these toxic forms of amyloid beta, the oligomers and protofibrils. The landmark study here was the Clarity AD study. It's an 18-month study, randomized control, 2 arms, lecanemab arm and the placebo arm. And now there's also an open label extension. You'll see the profile of patients in the table below. The mean MMSE was 25. So we are talking about using these drugs at the very earliest stages of cognitive disease. These are people who are almost very functional, right, near normal, but they have evidence of amyloid in the brain detected either using a PET or a CSF. And these were the findings. Significant improvement in cognition. They used the CDR, a clinical dementia rating that does not only measure cognition, but also functional abilities, social abilities, home abilities, and a 27% slowing, right, of worsening of cognition and function in those who had intervention with the lecanemab. From the PET imaging perspective, again, I think really remarkable findings. You'll see that from month 3 onwards, the 2 lines diverge, showing significant decline in amyloid with treatment with lecanemab. On the PET scan, you'll see that in patients with placebo, no major change between the baseline and 18 months, but in patients who were receiving lecanemab, in fact, all the amyloid almost melted away. So if we believe that amyloid is the upstream cause that causes neurodegeneration, which then causes cognitive decline, and if this drug can then remove the amyloid, definitely from a biological perspective, this is a drug that will reduce and even perhaps prevent dementia. And the studies have also shown that it results in improvement in cognition. The second drug that was FDA approved is donanemab. from the Trailblazer study, very similar protocol, but they also had tau PET as the inclusion criteria to stage the disease. Again, significant improvement in cognition, in amyloid, and here the CDR decline was even more remarkable than lecanemab. 36% slowing in CDR in patients who are receiving donanemab. Like all drugs, there's always a concern about side effects. While they are efficacious in terms of clearing amyloid, improvement in cognition, slowing of CDR, there are side effects, what we refer to as ARIA, or amyloid-related imaging abnormality. This happens because the amyloid from the parenchyma moves into the vessels, and vessels become more fragile, and has been reported in about 15 to 20%, although the serious events is about 1 to 2%. So again, something that we have to be careful when we select patients for anti-amyloid therapy. So in conclusion, I think early dementia is currently underdiagnosed. The need for greater awareness. AD pathology, vascular pathology contributes significantly to early dementia. There's a need for combination biomarkers, combination of digital neuroimaging, and most importantly, blood-based. Management, of course, should include non-pharmacological and pharmacological. We talked about cognitive stimulation. There are cognitive enhancers such as EGB and Potassium Connect. We have newer disease-modifying drugs, more to come. Again, be careful on who we select these drugs for. But there is a gap in terms of disease-modifying therapy for vascular causes. Again, something that we are looking at at the Dementia Research Centre, Singapore. So this is my team that contributed to a lot of this work. And thank you so much for this opportunity to share. Thank you.
Thank you, Dr. Kandiah, for an excellent lecture, which is really a very quick review of the current status with regard to MCI, dementia, new methods of diagnosis, the risk factors and biomarkers, and also the treatments. We've started to get some questions, so I will start by trying to put the questions to you. Maybe request you to stop sharing screen.
Yeah.
So an anonymous attendee says, I'm 64, my mother had dementia, and I'm now facing some forgetfulness issues. Do I need to take an early detection test for dementia?
Okay, so I'll try to answer that. Yes. So 64 is that age range when the bad proteins begin to accumulate, and the fact that there's a family history, I think that should warrant some concern. So it would be best to get checked by a doctor, where I think a cognitive test needs to be done to know for sure whether there's any cognitive impairment. I think that is quite useful.
Just to subsidiary to that, if I may ask you, you highlighted that there are people who are subjectively complaining about their memory, but not necessarily symptomatic yet. Mm-hmm. How frequently should they get themselves checked?
Yeah. So while we don't want to overdiagnose, sometimes we use the term worried well. You're well, but you're worried, right? We don't want to overdiagnose them. But again, studies from us and others have shown that these people actually have a higher risk. To actually follow them up, they have a 3 times higher risk of actually developing dementia compared to someone with no symptoms at all. So what I normally do is, for patients like this, I will evaluate them, I'll reassure them, I'll advise lifestyle changes, cognitive stimulation, but I will not discharge them. I'll see them at least one more time after a year. If things are stable, then I'm happy to let them go. If not, then I'll do more investigations.
Thank you. There's another question from an anonymous attendee. Does playing memory games like Sudoku, etc., prolong the onset of dementia?
Yes, indeed. So any form of cognitive stimulation, right? Sudoku, crosswords, all are useful. What they do is it increases your cognitive reserve. So the connections between brain cells improve in simple terms, which means that even when you have the bad stuff like amyloid accumulating in the brain, you have more reserve to fight these bad proteins, and hence your onset of symptoms becomes delayed. So it is useful.
Thank you. Dr. Srikala Bharat wants to know, what is the follow-up duration of your digital apps, which are developed by your setup, and what language do these apps use?
Right. So, how often to follow up? I think we know that there's a learning effect. So I would say the minimum interval between the two should be 6 months. But again, going digital, we also want to give people the flexibility of testing more often. So we are personalizing it. We are making it so varied that they may not have much of a learning effect, and you can do repeated testing at a shorter interval. But traditional answer is about 6 months. Now we have now doing the demand study in 6 countries. So we have now the English version, the Mandarin version, the Thai version, the Malay version, not yet the Tamil version yet, but again something that we would love to be doing, maybe in collaboration with someone in Chennai.
Wonderful. I'm sure that there'll be people in the audience who are very happy to participate in this, Dr. Kandiah. Professor Mohanshankar, there's a question from Vivek. While mapping the brain at cellular and electrophysiological level, where do we see ourselves in mapping the brain of people with mental health conditions? And are there any reference atlases being developed?
Yeah, so that's a very important question, right? Because in fact, it's totally lacking today. In fact, there is nothing, right? I mean, you don't even, well, you have some MRI, but So we have acquired brains with no neurodegenerative documented. So in fact, ESK and I keep talking about it. It's probably the time has come to even create a cohort, and especially with the kind of work Buddhi is doing. And many of these patients are actually willing to donate this brain post-mortem, except that it will be even more valuable if you have a documented clinical history. Right? And of course, there is a logistical challenge around the brain acquisition itself. People get cold feet. Well, I mean, not the patient themselves, but usually after the death, the family. Recently, we had a situation of MS. The family was absolutely keen, but just after the death, they said no. So this is something that we should address. So we have acquired a few brains. In fact, recently we had an MR brain, which is quite rare. In fact, you can visibly see that it's quite different. I mean, almost 70% smaller than that age group. So getting these patients and families informed, number one. Number two, having a cohort so that there is a proximal longitudinal, if not 20 years, even 3 years, 4 years, will be important, right? So we are doing that. In fact, in about 6 months or 8 months, you probably will have the first Alzheimer's-like dementia, because we don't see that much amyloid, but definitely this is severe dementia and degenerated, almost 89 or probably even 90 years old. So that is probably the first time that the world will have a cell resolution known dementia brain. But we are looking for people to come forward, and this is something that Buddhi and we should work together to expand this.
Thank you. We've often spoken about the need for advocacy and the need to get people to voluntarily donate their brains for research. And I think it's a very, very important message that needs to go out, that if you have a diagnosable illness and you're being followed up for a diagnosable illness, a center like the IIT Sudha Gopalakrishnan Brain Centre has the capacity to look at this in great detail after one's life, and that will be a huge contribution both to science and to society. So I think the webinar is also an opportunity to reach out to people to say, please do consider being a brain donor for research, because future generations are going to benefit from the knowledge that is gleaned in this way, and we have the cutting edge technology to look at this today. Dr. Kandiah, a question from Rafat Parveen. MRI and EEG reports are normal, but PET scan indicates likely AD. The medicine prescribed is donepezil. Your advice, please.
Yes. So I think the PET scan here, we are referring to the FDG or the FDG PET, which basically tells you about glucose metabolism in the brain and some suggestion of neurodegeneration, but not specific for amyloid. So perhaps I suspect that the scan showed some FDG low uptake. So there is evidence of neurodegeneration and dementia, and that's why it was started on donepezil.
Thank you. The same person wants to know if they can contact you. I'm going to request them to email us at Buddhi Clinic first, and then we will facilitate
Yes.
a meeting. Shobana Reddy wants to know, does listening to or singing classical music better the disease?
Yeah, I don't have the specific answer to classical music, but to all kinds of music, I think have shown using functional MRI studies have shown that with music, based your connections in the brain, the functional connectivity between the nodes increase, especially in your frontal lobe. And as I was alluding to, cognitive reserve gets better and hence definitely helpful in the prevention against dementia.
Thank you. An anonymous attendee asks, I'm a male, age 67, have dyslipidemia, and I'm occasionally unable to recall people, incidents, or facts. Should I take a test, Professor Nagaendran?
Answer is yes, right? Because if you believe in early detection, then I think at this stage it's important to know whether this forgetfulness is just part of normal aging or could that be an underlying brain disease? And if so, what can be done? So need to be tested, yes.
Thank you. Dr. Vindhya Rani asks, my recent memory is good. My remote is sketchy. What do I do?
Yeah. So the typical progression is often the short-term memory that becomes affected first. This could be when your short-term memory is relatively intact, but your long-term memory is not so good. Sometimes this happens in a very busy lifestyle, right? It's more of a problem with attention and focus rather than a problem with the brain storage. So I wouldn't be too worried, but again, maybe some lifestyle changes will be useful.
Thank you. There's a question from an anonymous attendee. Does consuming coconut water, flesh, oil, etc. help, and in what way? And if I can add a subsidiary to that, your thoughts about organic coconut oil as preventive for dementia progression, and also about turmeric, because these two things are things. In fact, three things. I'll also add red wine to it.
Yes.
If you can tell us about how these things may help or may not help.
Yeah. So firstly, coconut oil, I think, was a hit about 7-8 years ago. Some literature was coming out, but unfortunately, the evidence is not too strong. And I personally had patients who became so caught up with this coconut oil, they started taking it quite frequently, ended up putting on a lot of weight and doing more harm to the brain. Right? So that was the worry. So maybe good, but at the moment, the evidence is not so strong. Now, curcumin is interesting, right? We are actually doing some work. The previous studies did not show any clear evidence of benefit, but I believe that this is because the design of the studies were not right. We know for sure that curcumin, based on our work, actually reduces amyloid levels, reduces neuroinflammation. But we need to get the right people into these studies. We need patients who have these problems, amyloid in the brain, neuroinflammation. So we are now designing this. Hopefully, we have better results over the coming years. I think red wine, similarly the same. The effects on the inflammation, the vascular effects are likely to be good, but again, in moderation.
So not an excuse to go to town with red wine.
Of course not.
Question from Vivek to you, Dr. Kandiah. In non-invasive brain stimulation, what are your views on transcranial pulse stimulation, TPS, using high-frequency acoustic waves to enhance cognitive function in MCI or Alzheimer's disease?
Yeah, great question. I was in the Indian Institute of Sciences in Bangalore yesterday for a talk. Again, some of this work was shared. I think there's a lot of new, exciting research coming out using pulse activity. We are using some theta burst pulse activity, focusing on different parts of the brain. And again, I think preliminary studies, especially in psychiatric conditions, in Parkinson's disease, this has been shown to be quite useful. More work needs to be done in Alzheimer's disease, but from a biological perspective, I believe it will be useful.
Thank you. Question from Mr. Jayashankar. Can slow amyloid buildup happen without any signs of dementia and vice versa?
Indeed, yes. So amyloid can build up. It takes a phase of about 30 years to build up before any symptoms develop. So if you live long enough, right, then the symptoms will appear. Unfortunately, if you demise due to some other reason, then your symptoms may not manifest, but it does have a slow build-up and definitely will manifest somewhere down the road.
Thank you. What mental exercises would you recommend for older people? Asks Sheila Mohan.
Yeah. So, I don't like to be too prescriptive, do crosswords. What I do is I ask them about what they normally do, and then I make a tweak to it, right? For example, a lot of our older patients watch news. They are quite obsessed with news, right? So what you could do, simple thing is, after you watch the news program, jot down a few things. What were the headlines? What was something that, got your attention? Make an active recall task will help improve their connections. So modify your daily routine to make it more of a learning journey.
Thank you. Mahalakshmi Ravi Shankar asks, my mother has dementia from 2014, very slow progress. Overall health is good. Now she has no memory of present existing conditions and talks only about her childhood. How many more years for this to progress and how to proceed? For how long? There's a subsidiary question. She is 84 years old, only in bed, no effort even to get up and walk. Everything is done in bed only.
Yeah. So looks like this the dementia has been going on for the last 10 years, right? 2014. And most likely this is the stage of severe dementia. So I would like to be practical about it. So at the stage of severe dementia, I think we're talking about supportive care, holistic care. Keep her happy. Let her do what she wants, right? It may be a few more years. So make sure that there's no harm, especially in terms of preventing infections. That's a major issue. The second thing is preventing falls. I think this is what I would advocate. No other major interventions, but just keeping her happy.
Thank you. There's a question from an anonymous attendee. How helpful is exercise, especially muscle stretching, building, and balance?
Yes, very helpful. So in the study that I shared, the finger study, one of the intervention arm was exercise. They had a combination of both resistance exercise as well as aerobic exercise. And there are also many other studies that they are quite useful. So definitely something that should be routinely carried out.
Ravi Shankar Rajagopalan asks, how effective are Admenta, that is memantine, and donepezil in retarding dementia progress?
Right. So these are both what we call as symptomatic drugs. So I would put it this way, right? So if your patient or if you have mild dementia, and we know mild dementia progresses to moderate dementia in about 3 to 4 years, right? In moderate dementia, your function becomes quite affected. So if you are in a mild dementia stage and you are taking or given donepezil or memantine, what happens is your stage of mild dementia becomes prolonged. So 3 years, instead of 3 years, then maybe 5 years or 6 years, which means that your quality of life is preserved. It may not improve your memory, in fact, will not improve your memory for sure, but it delays worsening. So in that perspective, it is useful.
Thank you. Here's a question that's going to challenge you, Dr. Kandiah. It's from Usha Ramakrishnan, who we call Usha Ka, who's a very eminent educational psychologist. She says, congratulations to all the great presenters. Since we are talking about holistic understanding and management of a brilliant human brain and mind, what is your opinion of the role of the soul and consciousness in all this?
You might be in a better position to answer that, but yeah, so I think at the end of the day, I think I look at it from a happiness perspective. Whatever you do, as long as you're doing it and that makes you happy, I think that you're doing some service to your brain. If you're doing something that you're not happy doing, you're forced to do it. So that definitely going to have a negative effect on your soul and on your brain. That's my 2 cents.
So probably I will add to that to say that Professor Michael Trimble, my former boss who taught me neuropsychiatry, wrote this wonderful book called The Soul in the Brain. And what he talks about is how art, music, and culture that move you are representations of the consciousness and the soul while we are still in human life and alive. And I think that one of the things that comes to my mind is to be able to engage with and enjoy the things around us, art, literature, music, and culture. I think it's extremely important that we do that. But also one thing I tell all the people I know and the people who consult me is also to consider taking up something new as a hobby. Because I think learning something new is extremely good way of protecting yourself from cognitive decline. And I think especially once you're north of 50, every 5 years something new is probably something very, very wise to consider. And someone's asked a question about chanting, for example. I very strongly recommend chanting for no other reason, not for religious reasons. I recommend it because it's usually in a language that you're not familiar with, like Sanskrit or Latin. And when you learn and use a language you're not unfamiliar with, then I think you are giving your brain much more exercise than when you try and learn a language that you're familiar with. So those are two little add-ons. So Ushaka, I'm going to rely on the soul as represented in creativity around us and engaging in creating endeavor as a way of connecting with our souls. I hope that is sufficient. I have a question from Vivek Mishra. Rather a statement. He says we'll be the first to test TPS in the country early next year for dementia. Vivek, would you like to say something?
I was just talking to people at Strauss Medicals, and the vendor, he says like we will be having the device. So I just wanted to know, like, is it just the Alzheimer's we should look for, or we are looking for a cognitive impairment? I think we will be having the TPS in Buddhi Clinic soon.
Wonderful.
In fact, I think Dr. Kandiah has already said that we should also look at conditions like Parkinson's disease and other degenerative disorders with interest when we have this new technology. I think we've kind of addressed all the questions that have been put to us both in the QA and in the chat. And I think it's wonderful to have such a well-engaged audience on a Sunday morning. And post a cyclone, it's wonderful that everyone's managed to connect, and we've managed to have a program go through quite successfully. And to formally thank all those who participated, may I invite Vaidya from Buddhi Clinic. I'll quickly read out what Dr. Nirmala Lakshman said. Thank you very much to Professor Nagaendran Kandiah, Professor Mohanasankar, Dr. ESK, and all at Buddhi for a wonderful webinar, which has been most illuminating, revelatory, and interesting. Much appreciated. Honored to have been able to attend. Thanks again. Thank you, Dr. Nirmala, and it's an honor to have you with us today. Thank you. Vaidya?
Good morning, all. On behalf of Buddhi Clinic, I extend my heartfelt gratitude to everyone who joined us for today's webinar. Although the event didn't go as planned at the IIT Research Park due to Cyclone Fengal, we are immensely grateful for the enthusiasm shown by all the participants and the speakers and the guests to adapt to the virtual format. Our thoughts and prayers are with all those affected by the cyclone, and we hope for a speedy recovery. This year also marks a special milestone, the 15-year journey of Dr. Ennapadam S. Krishnamoorthy, founder and CEO of Buddhi Clinic, in advancing brain and mind health. Over these years, Buddhi Clinic's innovation and integrative approach to neuropsychiatric care and commitment to combining modern science with the wisdom of ancient tradition have transformed countless lives. Today, we celebrate not just this event, but the journey of excellence and inclusivity that Buddhi Clinic and team have built over the past 15 years. We are privileged to have Associate Professor Nagaendran Kandiah as our esteemed keynote speaker, Professor, a renowned neurologist and researcher specializing in dementia. Sir, your lecture illuminated the path forward in early diagnosis and intervention on MCMI in dementia. Inspiring talk to all the attendees, sir. We are also deeply honored by the presence of Dr. Nirmala Lakshman, publisher and chairperson of the Hindu group of publication. As our guest of honor, your support and encouragement have added immense value to this occasion, ma'am. Thank you very much for joining us. A special thanks to Professor Mohanasankar Sivaprakasam and the Sudha Gopalakrishnan Brain Centre for their invaluable contribution. Professor, thank you for your invitation to visit the Sudha Gopalakrishnan Brain Centre, a state-of-the-art facility at the IIT Madras, dedicated to advancing research in brain science. Thank you, sir. Thank you for the talk and presentation. Our gratitude extends to Marindeshwar Enterprises, Srikas and IIT Research Park for their tremendous support in helping us put this event together. Even though we couldn't host the in-person event, your efforts were instrumental in ensuring a seamless transmission to virtual platform. Thank you all once again. We look forward to your continued support in the future. Stay safe and have a great day. Thank you all.
Thank you, everyone, and namaste. Have a wonderful, blessed Sunday. Thank you.